Good afternoon. Thank you for joining us. And I'm really pleased to be able to be moderating this session with Ewout van Ginnigen, the director of the Observatory on Health Systems and Policies. I'm Natasha Tsopardi-Muscat, director of Health Systems at WHO Euro. And this is a joint endeavor together with the support of Gastein. And thank you, Luis, for really helping us get this session together. And it's very fitting that we're going to talk about the value of care on the day of older persons today, because most of our efforts towards financing and providing good quality care actually do go towards older persons. So at WHO Euro, just a few weeks from now at our regional committee, we will be presenting and discussing our forthcoming strategy on the health of older persons. And one of the main pillars in this strategy is talking about reimagining our care ecosystem. We know that unless we get care, and particularly long-term care, right, our health systems' sustainability is at stake and at risk, as well as the resilience of our health systems. So today, we want to have a deep dive, not only in the economics and financing behind care, but also in the delivery and what it means for people. And we've got a great session lined up in the next hour or so.
Indeed, and just to keep it really short, because you don't want to listen to us, but to our participants, we will have two excellent panels. One that is really looking into the investment case and why invest, and a second really in what to invest in. So I think these are the two large questions that we're addressing. And we as Observatory are also moving much more and doing more in long-term care. We always had a large portfolio on the economics of aging. That also leads us to ask the question, okay, what are the different models and new transformations that we need? And therefore also we will focus more on long-term care. Anyway, so I hope that everybody enjoys. It's also very interactive. We will have online participation. Dominic is going to keep an eye on that. We will also plan to have 10 minutes at the end to have also more, questions and answers with the audience, if all goes to plan. But we're already a tiny bit late, so
let's
we need to hurry up.
dive into the next section immediately. And we thought that to really be authentic, we need to start with real people. And we're delighted we should online have Kevin and Helena joining us. And Kevin lives with dementia, but not only, he is actually active in Alzheimer's Europe in the group on persons with lived experience. And Helena, who cares for him, is actually also in Ireland the president of the Carers Association. Kevin and Helena, thank you so much for making the time to be with us virtually in Gastein today, the day where we celebrate older persons. And we would like to hand over to you because we feel that this is really the right way to start our session this afternoon.
Hello, everybody. I am full-time carer for my husband, Kevin, who has young onset Lewy body dementia, a disease which is progressive and life-changing. Kevin was diagnosed at age 53, having been diagnosed with Parkinson's 2 years earlier, and due to his age, it seems that he has ended up a displaced citizen, as services for people with dementia in Ireland is somewhat lacking if you are under the age of 65. It is hard to believe that in 2025, some people with dementia are still ignored and marginalised by society when living with this incurable and sometimes invisible disease. But then again, out of sight is out of mind. As a spousal caregiver, I experience this disease up close and personal. Each day presents new challenges. I have learned that dementia is a family disease affecting each member in different ways. But it is also important to acknowledge that for carers of those people with younger onset like myself, not only do we lose all that we once had, but we also experience a huge loss around the hopes and dreams of the lives we had planned together with our partners. That leaves us in a state of grief, often feeling powerless, hopeless, and helpless. I need to remind myself frequently that I am doing the best I can. And as the saying goes, your best is always good enough. With dementia, all too often we speak of community, and sometimes we believe it is just family and friends. But community means a lot more, and we need to be aware that the goodwill of our carers should never be exploited, but all too often that seems to be the case. As chair of the Dementia Carers Campaign Network, which is supported by the Alzheimer's Society of Ireland, I can see clearly the value of our unpaid and undervalued carers. Our current health and social care system depends largely on family carers who provide the main bulk of care. Our political advocacy can influence policy, and we work tirelessly throughout each year, but this is most visible in our annual pre-budget submission when we ask government for financial commitment for the needs of people living with dementia, their carers and families. We call on policymakers to invest in home care, dementia supports and services, and most importantly, to reduce reliance on residential care, which in turn will reduce the financial burden on the state. So please remember, care for the person with dementia is care for the carer and their families. Thank you.
Thanks, everyone. Thanks, Selena, and thanks for having me here. I must say I get a little bit nervous when I hear people talking about older persons with dementia, because I've been an advocate for so long now. I'm just thinking, what about us? You know, are we being forgotten about? I know we're not, but when we hear older persons, then it automatically, for a person like me who has dementia, moves us out of the equation in my mind. Now, I know you don't intend to do that. Care and support, where does that come from? How does it start? The toughest thing that ever happens is you get a diagnosis and you sit with that for a time. Whether it's a short time or a long time, it doesn't matter. That's okay. But when you choose to tell people, friends and family members, some will run like they've never ran before away from you. But a lot will stay, and others will come. And they are the ones that give you the confidence they want. They'll give you the confidence to be yourself. They give you the confidence to speak. And for me, I suppose my community means everything. And it was getting involved in my community, letting people know in my community that if someone has dementia, it's okay. You know, it's not your fault. And if you're diagnosed early enough, it's not the end of the world. Your life just changes. And sometimes, and I'm lucky, for me, my life has changed for the better. I want you to hear this. If someone says to me what it's like to live with Lewy body dementia, I have no idea. I have never lived with it. It's my wife who lives with it. I have it. And that is the main difference. I have no idea what it's like to live with it. And I'll give you an example. About 2 years ago, I got my hearing done. And I said to Helena one day, I think I'm going half deaf. And she said, yeah, I've noticed that for quite a while. And that's only one of a number of examples I could give you. So they're living with it. They're seeing it progress ever before I do. And we are the voices of the lived experience. Helena is, and with the greatest respect to everyone there and everyone speaking, we are the experts. Helena and all the carers are experts in what it's like to live with the disease. And I'm the expert in what it's like to have the disease. Our lives are the lives of the lived experience. And we need to be at every table when people are making decisions about us. Because, as I've often said, if you had a sore tooth in the morning, you won't go to a plumber, you'll go to a dentist. So if you want to know the expert opinion on dementia, and in our case, Lewy body dementia, then come to us. And I'll finish with this. The most important point is, and it has happened to us, we went into my neurologist, and my neurologist asked both of us the exact same question. How did Kevin sleep last week? Or how did you sleep last week? She actually asked me first. And I said, I had the best night's sleep I had in a long time. And Helena looked at me and she said, that man didn't sleep at all. So you're getting the same question and completely different answer from two people who live together. The best look at your confidence, and thank you so much, and I hope I made some sense.
Well, thank you so much, Kevin and Helena, for these stories and how powerful this is, and also really showing why we're here and put a face on what is otherwise perhaps a bit of an abstract session. So thank you so much for that. I also think that many probably connected it to situations they see in their families. Now we will go to John Silas, my colleague from the Observatory, also works for WHO, a shared resource. John, why don't you walk over and give his presentation, short presentation.
Very short.
No pressure.
7 minutes.
7 minutes.
I'm counting the whole time.
Perfect.
So thank you. Oh yeah, that's me. Let's keep going. Is there another way? More. Enough of my face. So I'm going to talk about this book that has recently come out. That was a joint product of the Observatory, WHO European Regional Office, and the WHO Kobe Center. Actually, I really enjoyed, enjoyed is not the right word. I was really touched by the previous speaker, because we really came at this topic because we felt that long-term care is seen very much as something of, this is older people, this is, people at the last stages of their life. It's sort of marginalized as a policy topic. And our goal with this book was to not only show the evidence base for how, what are best practices in long-term care, but also to make the case that investing in long-term care is important for everyone. So just to quickly motivate the book, I wanted to start off with this slide looking at population aging. This is actually from a simulator called the PASH simulator, which is something developed by the Observatory to look at how aging affects health financing, but it's also a convenient place for me to screenshot demographic data. So this is looking at Austria, age demographic projections through the end of the century. And you can see, much like the rest of Europe, population is aging. In 2024, about 3% of the population was over age 85, and this is expected to more than triple to 10% before the end of the century. And of course, aging by itself is not necessarily a problem for societies, for economies. It really depends how people age. Do they age in good health, or do they age with functional limitations? And so to understand how people are aging in Europe, I use this indicator from Eurostat, which is healthy life years at age 65 as a percent of life expectancy. Healthy life years reflects reflects activity limitations. And so it's really a good marker for how, whether people will need care or not. And you can see, again, focusing on Austria, which, let's see, can I use my fancy pointer? Yes. Austria, if we looked back at 2005, about a third of years of life expectancy was expected to be spent without functional limitations on average. And that's increased to almost half of life expectancy. So people are living longer, but also living more years in good health. And this is the case for many countries in Europe, but not all of them, as we can see on the right. So many countries, Malta, Italy, Luxembourg, Spain, I mean, it goes all the way across. People are spending, they may be living longer in most of these countries, but they're spending more years with functional limitations than they were before. And functional limitations are an important predictor of whether people will need care, whether people will need informal care, whether people will need formal care, informal care or formal care. But if we look at the difference between people's likelihood of needing formal versus informal care, functional limitations are not the only predictor. It's marital status, it's income, it's education, it's having adult children living nearby. These other factors that determine whether you receive formal services. And one of the reasons for this is because of the chronic underinvestment in long-term care. So this slide here shows just the health component of publicly financed long-term care. It's looking at average annual growth in long-term care spending, public long-term care spending for people over age 65. And I've broken it down into the, into the pre-COVID period, 2013 to 2019, and the full, and the full period, the full decade, 2013 to 2023. So in orange, you can see that in many countries over here, actually, countries were spending less per 65-year-old on long-term care in 2019 than they were in 2013. This is in nominal terms, not adjusting for inflation. Many countries were spending less. Of course, many countries are spending more, and we can see that since COVID, many countries have increased their investment in long-term care. So we see the blue line is higher than the orange line. And you may look at this and think, okay, well, many of these countries are, growth is increasing a lot on an average annual basis. But the countries that are to the right of this figure, Estonia, Greece, Lithuania, Romania, Latvia, these countries spend very low levels on long-term care. So the high rate of growth just reflects the fact that they're coming from a very low baseline. Next slide, please. Thank you. And so one of the consequences of this underinvestment is that people spend more, are responsible for financing more of the costs of long-term care out of pocket, especially if we look at this compared to how much of the costs of care are paid for out of pocket for healthcare. So on this figure, in orange, this is the out-of-pocket share of long-term care spending, and in blue, it's the out-of-pocket share of current health spending. And you can see that even in well-developed or relatively well-developed long-term care systems like Germany, France, the UK, sort of developed, Austria, there's an expectation that people will bear more of the costs of care out of pocket for long-term care than they will for health care. These data come from just before COVID, actually. And so if we go to the final slide, So as I mentioned at the beginning, this book is aiming not only to bring together the evidence base on how to invest in long-term care, but also to make the case for investing in long-term care. Why does investing in long-term care benefit not only caregivers and care receivers, but society, economies, health systems? And so the book talks about things like how investing in long-term care can reduce pressures on acute care, free up resources instead of having people stuck in hospitals that don't need to be there. Again, making it freeing up resources so that people that need acute care services can obtain them. Investing in long-term care is good for the economy by increasing labor market participation, particularly among women who oftentimes are caregivers. And even if people are going to act as informal caregivers for their family members, the people who are not in the labor market oftentimes lose access to pensions. I'm almost done. Lose access to pensions. So it's really important to think about these. By investing in long-term care, you can improve people's economic outcomes. Household finances, I talked about already, but there's an increase in the risk of poverty at the onset of providing care. Investing in long-term care can be important to combat this. And finally, societal well-being. I like animation. investing in long-term care can improve social solidarity. There's lots of innovative mechanisms that have been used to improve access to long-term care. So it's really a source of social innovation. So in my 7 minutes, which I'm sure I've overused, there's not time to go into this evidence in detail, but this is the kind of material and the kind of narrative that we're trying to shape in the book. So thank you for your attention. I pass it back to Eva.
Thanks, John. Well, actually, you were remarkably in time, and indeed, do download this book from our website. So now we will go into the first small panel. So I would like to invite Flaviana Theodosiou to the stage here, and also Peter Alders. Flaviana is a team leader in long-term care at DG Employment, Social Affairs and Inclusion. And Peter Alders is a program manager in the Ministry of Health in the Netherlands. And you also work, well, in your portfolio a lot on long-term care. So I think I have the right people here. And I would like to start with Flavia, but I see that you, well, I can perhaps help. I can make one for you when you talk. I'll pour some water for you. So let's start with you, if that's okay. The European pillar of social rights and the European care strategy all emphasize financial protection and affordability as really a key to have access to high quality care. So when you deal with policymakers, what are the benefits of investing in LTC? How do you sell it? How do you summarize it to policymakers? You should have one, and Peter, you have one too.
Okay, how do I turn it on?
And you don't have to, I think it's on.
Okay, yes, it is indeed. Thank you. So, of course, financing of long-term care is up to the member states. Yeah, what I can provide is the European level perspective by looking at how much they spend. Nowadays in Europe, in the European Union, the average spending on long-term care is 1.7% of the GDP. But this covers huge variations from the Netherlands, and we have the country represented to my left, which invests 3.8% of the GDP, to Greece, which at the other end of the spectrum invests 0.1% of the GDP. Actually, it's about 10 member states which invest less than 0.5% of the GDP in long-term care. And what I can say is that we see a high correlation between inadequate funding and, let's say, poor performance at the level of LTC outcomes. When I'm talking about out-of-pocket, I'm talking about coverage, I'm talking about workforce ratios. So there is this correlation. So, of course, adequacy of funding goes hand in hand with sustainability. It's a binom that has to progress together. For us, it's clear that the long-term care is a social investment. And John very eloquently made all of these points, so thank you very much. But I will add maybe a few things myself. Social investment with returns for the individuals, dignity, work-life balance for informal carers, and so on and so forth. For society, I'm thinking of poverty and social inclusion, because obviously with the right services in place, if they are affordable, you can prevent poverty risks associated to the onset of long-term care. Then I'm talking gender equality. The long-term care sector is a highly feminized sector. It's nearly 90% women working in the care workforce. By investing in the sector, you invest in gender equality. Same link same thing because it's more informal carers, they are more women. So by investing in care services, they can, if they so wish and if they can, be more active on the labor market. That means also preventing their poverty in old age, because with spells of not being on the labor market, then you end up with smaller pensions. So then you end up with old age poverty. There is a well-known poverty gap, a gender gap in pensions. So these are a few elements that for us are very important for the policymakers to know. And then maybe I will add also that there is a huge job creation potential in the sector that shouldn't be overlooked. It comes with aging, and you very eloquently provided some numbers. I can add from my side, from our own calculations. From here to 2050, we are going to have roughly 8 more million persons with care needs. We will need, again, estimated 1.5 million more care workers. So here comes. This means more money to the public purse from taxation and social security contributions. So that's another investment, a return to investment. And my final word on this is that not only member states should ideally pursue this investment, but also we are doing it at the union level as well through a range of EU funds. And I'm just to put some numbers to it, the Recovery and Resilience Fund and the European Social Fund Plus, put together, it's about 15 billion euros that have been invested over the last 7 years in long-term care, funding both reforms, but also investments in care infrastructure, investing in delivery, more person-centered, integrated delivery, investing in the human capital that is supposed to do the job, and so on and so forth. So, yeah, I will stop here.
One very quick follow-up, maybe in 30 seconds. Does your message resonate with policymakers? Do they understand all the arguments that you were making and that John were making, or do you feel something is missing here?
I think that the take-up at country level, we are very happy. The take-up of the long-term care recommendation, it's a council recommendation, so it's not the Commission telling member states what to do. It's the member states telling themselves what direction should pursue. We've set up, the implementation plans that member states submitted last year show a lot of ambitious reforms in long-term care, but I must say that we are hearing also concerns when it comes to funding, especially in this complicated geopolitical situation where there's a lot of competition for the same pot of money. So yes, there is a lot of willingness to continue, but we also see countries struggling, especially in the East, with making ends meet.
Yeah. Then we almost have a little bit of a bridge to a country, the Netherlands, where spending on LTC has been very high. And I remembered we also produced with the Observatory these country profiles and hits where we describe countries. The moment where LTC spending overtook actually spending on primary care and, on outpatient care and inpatient care. So spending is very high in the Netherlands. The question for you, Peter, is why has public and political support for LT's long-term care sustained and remained in the Netherlands?
Well, first of all, of course, it's about political weighting. What you think is really important, and so you really have to weight the extra budgetary cost to compare to the alleviating of the family burden, basically of providing care, actually. It's really about social values. It's really about cultural values, and we know as well that in countries with stronger family ties, there you have a less long-term care insurance. So in the Netherlands, actually, we have always discussion about how much money we should spend, and we should always spend less. But we never have an argument or a discussion about whether we should invest in long-term care. And I think you can look at again to the cultural values in the Netherlands. The Netherlands was the first country with long-term care insurance since 1968. So really, like compared to Germany, I think that was like 30 years later. And if you look at the values in the Netherlands, that might be part of the explanation. So the Netherlands is a society which can be characterized as a feminine and as well individualistic country. And individualistic societies basically care about themselves and about the family around them. And with a feminine society, it's really the things like solidarity and caring for others are really the basic values. But as well, you don't have to give the care themselves. So the family is more a loose something compared to the masculine countries. And if you, basically in the Netherlands, we look then more to the state than providing the care ourselves. And if you look at that way, you can really explain basically why in the Netherlands it's like that. And one more important thing with that as well, that the moment we have this long-term care insurance, and you really have the nursing homes and institutions, things like that, it becomes as well a default option to let someone go to a nursing home. It's socially acceptable. So once you go there, it's as well enforcing or strengthening the cultural values which are already there.
Thank you. Yeah, and I think it does really reflect on Dutch culture. Indeed, I remember, working in an international organization, talking to people about, grandmother has to go to a nursing home and they are impossible. So I think, this is probably a big explanation for that. Flaviana, coming back to you. Well, maybe there's this myth that the spending on LTC is a drag on the economy. It will perhaps hinder investing in competitiveness or in innovations, etc. How do you think can the care strategy help improve and help investment in skills, human capital?
Well, I hope we debunked already this myth with the first part of the presentation. But just to add a few more points here. So it's clear for us that competitiveness and the social model that we have now in Europe, it's not a zero-sum game. Actually, investing in care is basically bringing returns, and it's actually reinforcing Europe's competitiveness. We talked about everything, including the job creation potential. So I'm not going back to that. I would maybe. There are some issues, for instance, when it comes to regularizing undeclared work. That's another thing that we haven't mentioned already. The care strategy and the recommendation asks member states to identify pathways to bring these people into formal employment, which first of all provides better social protection for the caregivers themselves, better quality of care, because you can have quality assurance systems in place. And thirdly, again, it returns to the public budget, because these become formal jobs, these become a source of revenue for the public budget. We have estimates, the European Labour Authority actually has estimated some 2 million care workers working undeclared. That's quite a lot if you think that currently, by the way, we count long-term care workers in Europe. These are about 3.1, 3.2 million. So it's quite a number, yeah. Then it's about informal carers. And here, how the value of their time, if you are to quantify, and we did try to quantify it, now you can always discuss the models and everything, but we did come to a number transforming their work, their hours investing in care into full-time equivalents, and this basically can be monetized to about 2.7% of the GDP. This is the value. This is the economic value of informal care work now in Europe. This is much higher than actually what countries spend themselves. I was just saying 1.7% of GDP. So this is the value of the work. Now, I'm not saying that there's not a million other immaterial benefits to this, and not all informal carers can work. Not all of them want to work, but to the extent that they want to work, formal care provision can support their more labor market participation for them. But formal care services are not enough. Informal carers also need a range of other things. They need work-life balance measures. They need flexible working arrangement. They need care leaves. They need respite. They need training. They need counseling. They need adequate social protection and care allowances. So all of these things can contribute to the competitiveness of our economies at the end of the day as well. Speaking of training, let me just add one thing, if I can.
A very short one.
Very short one,
okay.
Because this relates to the training needs of the informal carers, and here I'm very happy that to announce in a bit of a avant-premiere that together with the WHO we have now in implementation of the care strategy, we are now ready to launch a training course for informal carers. So we hope this is going to be well picked up by the member states themselves. Stefania will talk about this a little bit later, but this is about having the self-care competencies, because one has to be able to take care of oneself before. It's a bit like on the plane, you know, before taking care of the other. So we really hope that this is also seen as an investment that member states can take and run with and use to support the informal caregivers in their countries.
I think it sounds like a very good initiative, and maybe we'll talk about it more later when there's more time. One final question for you, Peter, really short if you can, and not an easy one. You know, is investment in long-term care sustainable given population aging, and especially also the labor shortages that we're seeing around us?
Yeah, well, I think you mentioned it already. The biggest problem is the labor shortage. At the moment, it's like 15% in 2015, actually, that's working in the healthcare sector. But in 2060, it's going to be one in 3 people on the labor force would be working on healthcare. So that's really not sustainable. And the people actually who normally provide care in long-term care, the people between 50 and 74, well, they are decreasing relatively to the people above 85, and that's decreasing rapidly as well. So really, you have to look at different ways. I think there are 3 ways, but one of the things is look out of the system of healthcare itself, and that's housing. And you really have to build communities. Long-term care is not really about only giving care. It's as well about it's social care, and it's often things like supervision. And if you build communities, and if, for instance, when you build a community with more than 70% of the people don't have a severe care demand, then actually you might as well, for a person with a partner of someone with dementia, might move into as well and can do the supervision. The people will themselves will organize activities, and so you don't need a formal caregiver to do to organize the activities. It's giving a meaning of life to the people who do that. It's preventing loneliness, which, for another way, gives them more demand. So that's one thing. That's really, of course, reablement is one of the other things, which is done in Denmark as well. So the people learn to learn the skills to provide the care themselves or the family. And third, reduce competition. In the Netherlands, there is like so many cars traveling around the same area to provide community care. Stop, and just 1 or 2 organizations providing the care. It's much better and easy to do the night care as well. And so that's the third.
Thank you so much. So interesting to hear that the country that is known for competition in healthcare is actively probably trying to get.
I hope I have my job tomorrow still.
Yes. But, so I have to unfortunately end it here. You can go back to the sit, and we'll get you back later here. I wanted to go really briefly to Dominique and to hear what we are hearing on the chat, and perhaps in the same time, so we gain a little bit of time. John and Stefania can perhaps already start to prepare for the polls. But maybe you could give us a quick, what is the discussion online?
Yes, thank you. At first, I want to mention that there is a very interesting question about formalizing informal care could expand financing, but also shifts the cost onto the healthcare system. So it's really interesting that we can ask ourselves, how can we ensure this model remains financially sustainable?
We just talked about it.
And so there was someone putting forward that there are countries in Europe where it's stressed that there are high and long that there are high investments in long-term healthcare, but in the statistics, the Netherlands show that the investments diminished in the last years. So it's
okay. So all food for thought we can get back to later. I think just for time's sake, I think we'll now go to the poll.
Yes.
Stefania from WHO, you haven't been introduced. Also our colleague.
Everyone knows me. I need no introduction. My name is Stefania Ilinka. I work as technical officer for long-term care at the WHO Regional Office for Europe. And if we can actually go before the slides to the Slido poll, please. We thought that we hopefully have convinced you that it makes sense to invest in long-term care, and it makes sense to invest in long-term care now. But what does it make sense to invest in? And the most important thing we try to do when we plan both health and long-term care policies is to keep them person-centered and aligned with the needs and the preferences of the population. So you're going to act as our little survey base here, and we kindly ask you to scan the QR code and answer the poll question. Can we have the poll question on the screen, please? No? Well, okay. Well, I don't remember it by heart, but I can read it to you.
It's very long.
It's not that long,
It's
John.
really long.
What type of long-term care would you prefer to receive should you need it in the future? And you have 4 options. It starts with care from a relative or an informal caregiver only, care from a professional or a paid caregiver in one's own home, care from both informal caregivers and care professionals in the home, and finally, care from professionals in a facility or a residential setting. So, should you need it, and let me tell you, I'm not sure exactly what your own expectations are, but statistics show that a person who's 65 years old today has a lifelong risk of developing long-term care needs that require intensive support that is over 70%. So I very much hope you are the exception to the rule, but it makes sense to think of what kind of care you would want to receive should you need it.
Stefania, it looks like we have some results. Okay. So,
surprises you at all?
Surprise? I'm not surprised yet. Hold on. We'll give it one more second. No, I think it's probably going to stay like this. Okay, so most people, about 2/3 of people, prefer to have from both informal and professional caregivers in their home or the community. Actually, perhaps surprisingly, at least to me, changes, constant changes. Residential care facility, 3rd. I would have thought that would have come last. What do you think? Stefania, what about you? What would you prefer?
We've been too slow. I think the audience has jumped a little bit ahead of us. I see some of you have already answered the second question. It's not surprising, no. This aligns very well with what I would prefer myself and what we know from the little survey data we have. People prefer care close to their homes in a combination of formal and informal care. But what do people actually expect to receive? And this is the second question in our poll. If you're being really honest and trying to look 30 to 40 years in the future from now, do you actually expect to receive the kind of care you would prefer, or rather a different type? This was the second question in our poll, and I saw before quickly a peek at the results. Please skip through. This is what you would expect.
Whoa, go back. Question two.
Technology is not cooperating today.
So this is, do you expect, fewer people expect to receive residential care than perhaps I would have expected. So it looks like fairly well aligned with what people want. What people want is fairly well aligned with what they expect, which I'm surprised at. What about you, Stefania?
I'm surprised as well. In fact, maybe this is a reflection of how selected our audience is. And if I can get my slides now, I can show you the results that have popped up in the Eurobarometer survey about 15 years ago. And in a more recent non-representative data collection on exactly the same questions in 2021. This is right after the pandemic. And what has resulted from that is that people do have a clear idea of what they want. They prefer care closer to home, but in fact, they expect that this will not be available to them. This is important. It's important because it shows we have fairly low trust in long-term care systems to respond to our needs and preferences. And rather, we expect that the safety net will be the most intensive type of care. How do we transform care? How do we transform care systems so that they're better aligned with the goals of sustainability, the goal of person-centeredness, but also the goal of providing the right care in the right place? Population aging, you've heard about it. The progressive aging of the older population, you've heard about it. You've heard about the feminization of care and the feminization of old age. Women are heavily overrepresented in the oldest population groups, which are also the fastest growing in Europe and globally. Does this drive care needs? Well, it's associated with care needs, but it's not age that drives care needs. And I want to make this argument as strongly as I possibly can, that it is disease and disability, the accumulated effects over the life course of disease and disability, which limit our intrinsic capacity. This is a very WHO term, but all it means is our physical and mental health attributes and capacities. And as these capacities diminish, we find it more and more difficult to function in our environment. What long-term care targets is functionality, is the ability to remain independent, to remain autonomous, to maintain quality of life and dignity in our environments despite declines in our own health, despite declines in our individual abilities. And I want to make the case that the most important lens to look at long-term care systems, if what we're interested in is sustainability and quality, is a public health framework. And it is a prevention-oriented approach across the life course. Why? Because long-term care is not just what we do when there's nothing healthcare can do anymore. That's a misunderstanding. We need to broaden the way we think about care and destigmatize it. There is always something we can do better to improve quality of life, to maintain independence and functioning. During periods of high and stable capacity, we can prevent exposure to risk factors, we can reduce the prevalence of disease that leads to disability. But even once capacity starts to decline, there's a lot we can do to rehabilitate, to stabilize, to recuperate some function, and to at least postpone further decline. There's also a lot we can do in our communities to ensure that despite the loss of capacity, people maintain functioning and independence. Technology is a key contributor here in self-care, in optimization of resources. The transformation of public and private living environments can help us remain functional and independent despite limitations in our individual capacities. Finally, some of us, many of us, will end our lives with periods of significant loss in capacity. Even in this part of life, there is a lot of potential for prevention. We can prevent institutionalization. We can delay further decline. We can maintain quality of life and dignity. There's always something we can do to improve things in long-term care. How do we achieve that? First and foremost, we need a spectrum of diverse, assistive, and rehabilitative services that have to happen in the home, in the community, in facilities, as needs become more complex in the population, but also as needs at individual level evolve over time. There's no one size fits all. We need as much creativity and as much diversity in the services we offer across care settings to offer the right solutions for everyone who needs it. You've heard about the investment in families. You've heard about the investment in informal caregiving resources. I won't repeat that. Access to assistive technologies, digital technologies as well, they're essential for self-care, they're essential for empowerment, they're essential for the optimization of the workforce. So again, as creatively as possible, deploying technology in a way that does not dehumanize care, that doesn't take away from the relational nature of care, but that leaves the people the time and space to focus on what's human in care. Community investment and enabling environments. So I hope it's coming through that much of what needs to be done doesn't only fall on health and long-term care budgets, but is truly a societal-wide investment. And I want to emphasize here again, in private and public spaces, home modifications, universal design requirements. These are essential investments in prevention of care needs so that the demand on services, which are labor-intensive and which are expensive, reduces. Finally, palliative and end-of-life care, and I'm sorry I won't be able to speak a lot about it, but there will be tomorrow a session dedicated to it. Quality of life means quality of death. the care journey finishes with a good quality death for all of us. So it's important that we think of these two together. I will end on very brief key messages and the fact that to achieve this, we truly need partnership. But partnership and coordination and integration have become a bit empty words. We need to put again the meaning. Community grounding and alignment across sectors, not just health and long-term care, but transportation, but urban investment, but social networks and environmental protection. Partnership between formal and informal caregivers, so that care is a meaningful choice for everyone and that we can be empowered to choose the care roles we feel we're competent to play. Balance role and responsibilities between private and public stakeholders with a view on equity and quality. I'll end again on the message that you've heard many times, but I want to say it again. Investment in long-term care pays off, and all the smart people that have contributed to highlighting the benefits of long-term care investment could not come up with the cost of inaction, because it's truly incalculable. We are putting at risk our own dignity and quality of life. We're putting at risk sustainability of our care systems, equitable opportunities for everyone in society, solidarity, social cohesion, and we are putting at risk gender equity, because there is no possibility to make progress on gender equity in today's aging world without addressing care. That's it. Thank you very much. Natasha, I give you the floor.
Thank you very much, and well done, Stefania. And we're running a bit late, but I'm delighted to now call upon Andrea Schmidt, who heads the Center for Climate Change and Health at the Austrian Public Health Institute, and Dr. Renzo De Gabriele, who is the Permanent Secretary at the Ministry of Health and Aging in Malta, but also a former medical school colleague from Malta. We graduated together in the year of '95. In this panel, we are going to focus on two elements. On prevention, how can prevention reduce and delay the needs for long-term care? And then also, I think, picking up on Stefania's last slide, there are several different actors in the area of long-term care. How do we balance the public, the private, the institutional, and the community? But straight away, Andrea, I was really intrigued when I learned that you wanted to talk about a prevention-oriented approach to long-term care. What does a prevention-oriented approach to long-term care mean to you?
Thank you so much, Natasha. What does it mean? What does it mean, especially also when we think about the world that we live in? We've already heard that that care needs will be growing. There are workforce shortages. I have another bad news for you, because the climate crisis is also going to increase care needs further and make people in need of care more vulnerable, as we've seen, for example, last year in the floodings in Spain, but also as we see every year in Europe due to heat waves, for instance. And when we talk about the prevention aspect, I want to also maybe follow up on this example of heat waves, because in fact we know that people who live alone and are socially isolated are at the highest risk of being affected by heat waves and die at home. And these are very often also people with care needs who live alone. And I'm telling you all of this because because we need a comprehensive approach. And this approach does not start when we are in old age, but in fact it starts from when you're not even born. In fact, it starts about which playground you can play in, which school you're attending, whether or not you have the possibilities and facilities to to move around, to eat healthily and sustainably also. So it's a life course approach that is needed. And we know that health promotion can help. Health promotion interventions are most important here, because we know that €1 invested in health promotion is going to give us 2 to 4 euros saved in future health costs. So that's one of the first things I want to say. But what we need to do here, and it has come also, it has been mentioned, we need to prevent aging unequally. Because this is really the group that will have the most difficulty in accessing, in affording, in being able to live a good life, even with care needs. And to give you just a few numbers, so we know that the difference between people with high education and people with lower education is about 5 years of life expectancy. We know that women are the ones that will face more disabilities, significantly more disabilities in old age, so they have less time in good health in old age.
Thank you very much, and I'm sure that Caroline and Alison in the audience have picked on that cue. We've just had the recent report launched by EuroHealthNet on inequity. It's important to keep this in mind, because basically we can do something about this. Renzo, we were chatting earlier, and yes, of course, Renzo, I call him Renzo. We were chatting earlier, and you told me with a sense of pride that you introduced 23 community services in Malta. I mean, that's phenomenal in the space of under a decade. What drove and facilitated this investment? And if you were to be able to share with us, which of those services do you think have had the greatest impact for countries maybe that can't do 23 in a decade?
So first of all, thank you, Natasha, and thank you to the organizers of the forum for inviting me. Yes, it's a very pertinent question, because when the focus was residential facilities, and we have seen it also in other countries, people at first are perhaps enticed to go into facilities because there is also promotion and seeing nice new facilities being built. But you don't realize, when you go in, you realize that you lose a lot of independence. You become institutionalized, which is a word which we are obviously trying to avoid to use nowadays. So, and it's also costly. We have also heard about the costs involved. And the key was aging in place, which is now what we are doing. And it was mentioned as well in a holistic manner. So it was very important, first of all, to address internal silos that create, because everybody likes to work alone, and that is a problem. The resources, human resources, are limited, so it's not possible. Financial resources are limited. You have duplication of services. So the fact that active aging has the health aspect in it, the Department of Active Aging has the health aspect, has the social work aspect in it, has also social services in it. We have transport, we have set up transport, so these are the services that are under one roof. So when you do an assessment, for example, you do a needs assessment, certain needs come out, and you have one entity that can then address those needs accordingly. So the fact that we are now integrated with the health department has also helped, because it has now facilitated care. We had the transport services. We have, like I said, active aging centers. We have now 35 in Malta, in Malta we have around 64 local councils. So practically we have now gone over the halfway mark, which help solitude. So this is a holistic approach that we have to. If you just tackle the issue from the health perspective only, you will leave these lacunae. So this was one element that helped us do it. And it's much less expensive also. So more efficient, less expensive, and this is where people wish to remain, like we saw in the survey that we just made. And I want just to mention the last point. For example, the budget for long-term care as regards residential facilities has gone up from 39 million to 80 million in these last.
So a doubling, basically.
Doubling, basically. So it's definitely not sustainable. And we're speaking about sustainability. We're speaking about cost effectiveness. We're speaking about efficiency. So, and when you compare it with the community services, and before I also used to manage primary healthcare, as you know, it's the most cost effective. And besides that, it's where people wish to be when they age.
Thank you. Andrea, let me come back. You mentioned the climate crisis, the flooding in Spain, the fact that long-term care systems probably haven't yet really internalized preparedness and response. We saw this in the COVID pandemic, but now we know that across Europe, health security preparedness has become very important. What needs to be done to make sure that long-term care systems are part of the public health architecture when it comes to preparedness and response?
Yeah, thank you for this question. And you said it yourself. So we saw it in the COVID-19 pandemic that resilience was not high in long-term care system, partly because of the fact that long-term care actors were not at the table when the strategies were developed. So that's, I think, also a learning that we can take. And also we need to, again, many of the things that we are doing in long-term care can, in fact, in health promotion and also the things that have been presented can, of course, make us more resilient also in crisis times. Now, just to give you and follow up on the example that was given also by Peter, I really liked your example also about the community solutions, because in fact, community solutions are going to make us more resilient also if you have acute events, extreme weather events, if you have heat waves, if you have another zoonosis and pandemic happening. So, and these are very realistic scenarios. And to make it a little bit more concrete, I would also like to add to the aging in place discussion, because it's sometimes I think we tend to idealize also the aging in place concept, and I would like to encourage us to really think more about community co-housing solutions, for example, that also ideally take into account ecological aspects. So to give you an example, there are in the Netherlands the green care farms. We have also dementia villages. And what does it have to do with climate, you may ask, but it was already mentioned in the context of the competition. And just to add on that argument, it's not just about the time and the workforce that we will need, but we would also have less carbon emissions, of course, if we have shorter distances. And these shorter distances are also an important element of resilience and preparedness, because we will have a network around, we will have these strategies. And that, of course, has to go hand in hand. And also it was mentioned, the built environment, the age-friendly neighborhoods. Think again of the example of heat. If I cannot go out because it's not a barrier-free way to a cool spot, or I don't have a bench there, or I don't have a toilet there, I'm probably not going to do it. And here we're talking about people that are not already overheated in their own homes because they lack insulation, they lack the built environment.
Thank you, Andrea. And indeed, our strategy for older persons has 4 pillars. Prevention, particularly focused on NCDs, but also immunization. Aging in place and creating the age-friendly settings and environment. Reimagining aging, so really fighting the stigma, elder abuse. And then, of course, the care systems. Renzo, a final question to you before we close this panel. You mentioned, of course, the increase in public financing, and we saw from John's graph earlier that for Malta, actually the out-of-pocket payments in long-term care are lower than those for healthcare. This is a sector where you are using public finances and you are often paying private, for-profit actors to provide services. Some thoughts on how to get this right. I know you've also tried to come up with some public-private partnerships that the evidence is very mixed on whether these work, how they work. Any experiences you'd like to share with us?
Yeah, we have now some experience because we have also engaged with private operators on various services. You mentioned the many services that we have, and I work also with my colleague, the other permanent secretary taking care of health, who is in the audience, Joe Katkuti, and we work well. And the key, I think, is that, like I said, it's also another silo. So if you are competing with the private sector, you get a lot of missed opportunities, but obviously you have to regulate, and that is one issue. So, for example, when I started my tenure, a contract was made of about 15 pages now. So now it's about 120 pages, and you have to do contract management, proper contract management, which is the key. So it's a synergistic approach that you have to take. Currently, for example, we outsource the buying of beds so that we get, if those who really need then residential care can have a residential care facility. And we do contracts and we do contract management. We have also set up an Old People Standards Authority, which I suggest many countries should look into, so have an authority that regulates the sector, that licenses the sector, does spot checks, issues fines, regulates the sector, because obviously if there is no control, there would be also a lot of funds that might not be accountable for. So you have to introduce, like I said, strict contracts, contract management, an authority that oversees these implementation of these contracts, and also the entities themselves, like, for example, one of the biggest long-term care facility model, like St. Vincent de Paul and Active Aging Community Care, have set up their own quality also assurance units to monitor these contracts. So I think from our experience, it has helped diversify the sector into getting, because the private sector, we know that there's investment and money is invested there. So the government has changed the perspective into getting the private sector, instead of competition, getting on board and having the result of having less out of pocket, because the service is practically given by the private sector, but has to be, we have a still long way to go on this for further better contract management and better enforcement of regulations, but I think it's the right path.
So it's a yes, but, or a yes, with. Thank you so much. And I'm sure that Stefania must have been delighted to hear you talk about quality. And I would like to invite Stefania, John, Peter, and Flaviana to join us once again here, because I think we do have a couple of minutes for questions. But before seeing out if we have questions in the room, I would like to give the floor to Dominique. Dominique is not only a young Gasteiner, but she is actually an advanced care nurse practitioner. And when you see a beautiful young person like Dominique, and we hear many statistics about people not wanting to join the care sector, I thought we should give her a spotlight and hear from her what motivated her to take up this profession and what gives her the joy and motivation to continue.
Thank you. I hope it's not only the beauty, I hope it's the expertise I'm bringing with me. So I'm a nurse, and as a nurse, I think we are the closest healthcare profession, that we provide care for patients. We listen, we detect changes and guide patients and families. So I see long-term caregivers as partners. That's for me really important. And as I spoke about my nursing profession, it makes my profession highly valuable, that I'm so close working with patients and families. So in my role as an advanced nursing practitioner in the geriatric field, I'm working especially for the elderly generation, the most enriching aspect is improving the patient journey. So I want to encourage again, as we speak about professional interdisciplinary teams that the informal caregivers are included in these interdisciplinary teams, and also the patients are part of it. So in the interdisciplinary teams where different professional perspectives come together, we want to deliver high value for the individual patients. So we want to raise the quality of life. We spoke about the end of life, especially there, we should think about the quality of life. So what is the value for the patient? To keep care professionals motivated and satisfied, we need models that enable carers to work at their full potential. So we need to stress that the care force has staffing policies aligned with patient needs. And we need continuous education for nurses, but also for informal caregivers, and to recognize the advanced roles. So I see myself in the profession where I think that it is really important to see that I can help informal caregivers to prevent things, to educate them, and help them that, for example, a patient with dementia could stay at home when there is an issue, like community nursing. So, and then we have the integrated interdisciplinary care and value-based care pathways, where we have really to focus on outcomes that matter the most for the patients. It's mobility, independence, and dignity. So thank you so much.
Thank you, Dominique, for staffing the newsroom. I don't know if there's anything that has come in, but maybe we have a minute perhaps to take a couple of questions.
I was hoping that we could steal back some of the music that we had at the beginning, no? The dance music. No? I think we could
a bit of confidence interval. So whilst Dominique is looking to see if there are any burning questions or reflections from that have come in through Slido, I don't know if you would like to see if there are any.
Shall we take 2 questions or really briefly? Yes. Caroline.
I will be really, really brief. It's just following up what you were saying, community nursing. I think this is really a great investment to make. What is your view on community nursing? How can we make sure that we invest in it?
Shall I take another question and then we go? Is there another? Yep. Your name?
Hi, my name is Jonas Suber. I was wondering about the impact of how we invest into long-term care. I think we touched a little bit on it with the perspective of Malta and the synergies of the private and public sector, but I was wondering, especially with Stefania and Jonathan, your perspectives of whether any investment into long-term care is a smart bet or whether some forms are a smarter bet than others.
There's an interesting question that has come in through Slido. Perhaps Dominique can read it out to us.
Yeah, and then we have enough, and then we go for one round. Yep.
What role does innovation play in long-term care?
Okay, so who would like to start? There were some questions immediately directed also to you. And well, you want to start, John? Brief.
Sure, very brief. I'm always very brief. No, just to answer the question about how to invest. I think what I'd like to say about this is I feel very encouraged by, even though Stefania and I were texting about the failure of the Slido and how everyone, their expectations and what they'd like were aligned, and we didn't expect that. I'd like to see that through a glasses half full perspective, that actually there is more investment, right? We saw Malta's doubled its expenditure. We saw that since COVID, there's more spending. And it does raise this question then, okay, is more spending by itself good, or are there ways to invest? And I think, again, sort of piggybacking on the Malta experience, I think that when you look at aging societies and long-term care and this, there's the potential for private equity, private interests to see this as a cash cow, right? And I think it's very important that this additional expenditure, right, this is a reliable source of revenues for industry, to make sure that there's strong regulators in place that can ensure that just because there is a continuous flow of money, that this still leads to better care and better access to care for people.
So maybe we can make it a final round and responses to questions as we go along. Flaviana.
Mic, please. Thank you. I would like to comment maybe on community nursing, because this is also one Austrian measure that was funded through RRP, but it's not to put the EU label on it. It's really because it's an excellent innovation. So here we shoot two rabbits with the same stone. This links to several policy measures that you can, it's basically part of these person-centered approaches. It's, we are pleading for having, and we are actually seeing more countries going for multidisciplinary teams, so really organizing services around the person and not following organigrams, where be they ministries or in municipalities and so on and so forth. But this links up to other things that can be done in a stakeholder way, like also the needs assessments. The needs assessment need to be comprehensive, and they have in this way you can capture not only ADLs, not only limitations, functional limitations, but also limitations when it comes to instrumental activities of daily living, like the ability to shop, or so there is a red line that links. That starts maybe with a comprehensive needs assessment and kind of follows through to the delivery model. Yeah. And on innovation, just to say that we did fund also social innovations in long-term care in Spain, in Austria as well, and in other countries through the European Social Fund. I think it's okay to make mistakes. I think this is what we have to systematically remember, that such funding should also, there's learning to be taken from both things that work and things that don't.
Can we now have 30 seconds for each, and we finish with you? Yeah. Yes. Is that okay? Sorry.
Yeah. So basically, as regards community nursing, that's definitely a core element in community care. We have 1.2 million patient contacts in a population of 500,000 in Malta, where we provide community and nurse and also caring services in homes. And we have introduced the geriatric assessment team, so that we also link between the secondary care if person is hospitalized and the discharge process. So there is this seamless transition. So it is core. As regards innovation, I just also had the opportunity to present, to give a talk in Abu Dhabi. It has to be part of the caring aspect. It's a tool to be used by healthcare professionals. So, for example, introduce the telecare on the move, but it does not remove the human interaction that needs to be central to keep caring of our loved ones. So they are tools, they have to be used, they will help us be more efficient, but we always have to keep in mind the personal aspects.
Yeah, I think crisis can also, both the multiple crises that we're seeing, but also acute crisis can be also a trigger for innovation. So we know that, and I think that we should use this, to be very short, this trigger also to develop funding models that are cross-sectoral and that are really aligned with a vision of a good life for everyone, for people with care needs, for older people, but also for others, and especially tackling inequalities in this context. Yeah, thank you.
Thank you. Peter.
Well, first, community care and nursing, of course, invest a lot. But as well look at new ways for providing care. So more into reablement, less taking over care, and trying more to learn, like actually Dominica said as well. So that's one thing. Second thing, innovation. Lots of possibilities of care there, of course there. AI will help us a lot with the administrative burden. We still have to look how, but that's one opportunity. Secondly, there is a lot of new innovations already with housing. For instance, the innovations can help when to go to bed, when to eat, things like that. So it can be all done within the home.
Stefania, I can ask you also to wrap it up a little bit. What is the key take-home message here for the audience?
Because the questions were so easy. I want to say just 2 words to the one about return on investment, which maybe was not tackled as much. I always say it's not the lack of evidence that's been holding back policy intervention in long-term care. And now we have a whole 300-page book to prove it. But on return on investment, we are weak on evidence. We know a few things, though. We know that prevention pays off. It's not always cheap, but it's always cost effective. We know that investment in assistive technologies has a return on investment somewhere around 9 to 1. We know that investment in informal caregiving resources is going to save us 2.5% of GDP necessary investment down the line. That we know. And then it's a very innovative sector, both in terms of digital and social innovation. We're great at producing ideas. We're not great at supporting scaling. And maybe the innovation we need to come up with is how to scale the good ideas that we have, from local champions to national level averages. In terms of final takeaway points, I hope we've convinced you that investing in long-term care is absolutely necessary for health system sustainability. I hope starting tomorrow you'll all be advocates for long-term care. It's definitely good for economists, it's good for gender equity, and at the very core of it is a vision of solidarity and partnership, which I hope aligns perfectly with this year's Gastein Forum. And we have many more allies than when we started the session.
I think so
right?
too. I'm convinced for sure. Thank you very, very much to all the panelists here, and also Dominique for the chat, and my co-moderator here, Natasha, and also you for your active participation, and also our online viewers. And I hope to see you in another session where we talk more about long-term care. Thank you very much.